Alrighty, I'm really excited for today's conversation because we are going to talk all things bioidentical hormone replacement therapy here with Layne. I highly recommend you go follow him at Hormone Specialist. That's his handle. He's got over 1 million followers on all of his platforms. I learn something every single time he posts, whether he posts about hormone disruptors or environmental factors that are affecting our hormones. He's a wealth of knowledge, and we're just going to have him jump on here any second. So let's go ahead and make sure that Layne can see us. Right. And if you have submitted a question, we got literally hundreds of questions. So we are going to answer as many as we can as soon as we get Layne on here. That said, if you start asking a question below today's video, what happens when you do a live is that it doesn't transfer it doesn't transfer over to the feed post because the live will become a feed post. So just understand if you're leaving a comment and then you feel like it doesn't get answered or it's ignored, you really do have to go back to the feed post. And here we go. Layne's about to jump on. You're really going to have to go back to that feed post. So let's see, Layne. Are you in here, Layne? Let's see, Layne. Come say hi, Layne. Okay, I do not see him. Let's see if he's having some challenges.
About that.
There we go. All right.
All right.
Sometimes it takes a minute. You know what I mean?
Yeah.
So I was just singing your praises, Layne, with over 1 million followers on all your platforms. I'm always learning something from you. So I encourage anyone watching today to please jump on over to Hormone Specialist. That is Layne's tag. He's got a wealth of knowledge in his feed. And just a little bit about your background, and you can stop me if I'm incorrect. You have decades worth of compound pharmacy experience, especially in the bioidentical hormone replacement field under your belt. I think you're semi-retired, but still a wealth of knowledge. I'm so glad you're here because this is such a hot topic right now, and it's clearly one of the most common questions I get, which is why I wanted you here today. So thank you for taking some time to
pleasure.
spend with us. Yeah.
I'm happy to do it. Thanks for the invitation.
Yes. So before we get started, because I want to give, Instagram's going to notify everyone on the hour, anyone that's sort of hooked up their notifications. I want to ask you some questions myself. These are not viewer questions. So one interesting, and thank you, by the way, for referring me to the bioidentical hormone replacement therapy conference, because my mind is blown. I've learned so much. It's one of those conferences I'm going to have to do again because the takeaways are just mind blowing.
Like drinking from a fire hose, they say.
Wow. Okay. Yes. And I'm not a prescriber like you. My jurisdiction is chiropractic, natural medicine, and nutrition. Those are my 3 board certifications. So I will not be prescribing, but I certainly do. Yeah.
Let me just clarify.
Yeah.
Neither am I. I'm a pharmacist, so I don't prescribe, but I consult, and in my pharmacy career, yes, I compounded those prescriptions and did a very deep dive into the clinical side with practitioners. So I don't prescribe either.
Yeah. So, but what I love is you're so knowledgeable. I mean, you don't have to prescribe to know this stuff. And, you know, one of the things after doing this conference this weekend, and I'm sure you're aware that we have, at least to my knowledge, over a dozen sort of online, they're hybrid women's health, telehealth companies that are specializing in perimenopause and menopause, for membership prices less than 100 a month. So of course I did a little experiment and I had to pretend to be a patient, and I won't say who because I'm not like that. But one of the problems, or one of the issues I found, and I'd love your opinion on this, is one, not only was the three physicians that I talked to completely had never heard of this conference, meaning to me that maybe they don't have the kind of knowledge that I would want somebody that's going to prescribe hormone replacement to me. But then in this sort of hybrid situation where you're doing this telehealth thing and then you get your hormones delivered to your door, not everything was bioidentical, but that's not transparent and that's not upfront. It was, we'll send you the lab kit, we'll send you the hormones, but then there's that whole misinformation that still continues. So what are your thoughts on this sort of business model for women, perimenopause like myself and a majority of my audience, menopause and beyond? What are your thoughts on this? Is it dangerous business?
I don't think any more so than folks doing it in their office. I think that with the pandemic, we got a lot more telehealth going on, and I think that's great because it reaches out and gets to more people. But this is maybe a good time to talk about what's bioidentical and what isn't.
Great.
Because and I can bring that perspective from the pharmacy side. There are bioidentical hormones that are commercially made. So don't make that distinction that it has to be compounded in order to be bioidentical.
Perfect.
But what you don't want is you don't want anything that is not progesterone. That's that USP progesterone, United States Pharmacopoeia. Nothing that has a similar name to progest in some way. And by the same token, estradiol. So that's manufactured as tablets. It's made as patches. It's made as cream. The most important thing is that it is estradiol. That's it. No similar synthesized product that is not estradiol. That would make it bioidentical. So there's those two. Testosterone, same thing. If it says testosterone, then it has to be. There are some commercially made testosterones for men, none for women yet. But so that's important to
No, thank you.
differentiate.
It is. It's confusing. Thank you for bringing that up. That was actually on the list. In addition to that, this is interesting. So, we have this sort of, I like to call it an epidemic of insulin resistance in America, because we have like 60% of American women walking around with it and they don't know it, right? Because when you go to that classic medical doctor office, if you're not in the pre-diabetes range, you're not insulin resistance because they're AKAs. So sort of in functional medicine, in my training, we've learned to dial that back to kind of get in front of the problem. So that said, so we have this epidemic, right? And we know what insulin resistance does to the body. It's one of the reasons why we can't get rid of fat where it goes and why. But when we're doing all the things and we're eating the right way to balance our blood sugar, one of the things I found fascinating from this seminar was how oral administration of DHEA literally not only creates insulin sensitivity, but this little bonus of the stress response modulation. And I talk a lot about toxic stress because in perimenopause, I feel like we wear a lot of hats and it catches up to us. So can you speak to microdosing or over-the-counter supplementation of DHEA and insulin resistance and the stress response?
I have to say, I have not heard that is an issue or a problem with DHEA. DHEA is an important hormone in its own right. It converts to testosterone and is the chief source of testosterone in menopausal women. So it is important. I don't know of I guess I'm not aware of that. I haven't heard that.
Okay.
That being an issue.
Okay. So
I know this, that you need women are, it's important. Some women will tell you that the DHEA that they take has more of an effect on their libido than the testosterone. Some women will say that, but in fact, what it is it is making testosterone. So what they're saying, I guess, is that just replacing that DHEA and sort of mimicking the natural course that the body takes, it goes to the adrenal glands in order to get that testosterone. Seems to be better for a lot of women. It's you want to level up above 300-400
Oh,
if you're a
that's
woman.
good.
And
Okay.
yeah, so I don't know. I'll have to look into that.
Okay. Yeah. Yeah. So let's do this. Let's jump into, because I know in the interest of time, we don't want to keep you, and we have a bunch of really, really good questions. We got hundreds of questions, and what I did was my best to kind of boil it down into the reoccurring themes. And the first question is, when you are replacing progesterone, is it important to cycle it 2 weeks on, 2 weeks off?
It depends on where you are in your life. If you're talking about a perimenopausal or a menopausal woman, then I would say no, it is not important to cycle that. In fact, if you cycle it, you're likely to bleed. You're likely to have some bleeding, and at that point in your life, most women would say, "Oh, why would I want that?"
Right.
So I would say no. If you're younger, and women do take progesterone at younger ages for different reasons. Sometimes people take it for headaches, for migraines, or just to help them feel calm. These are women still in their fertile years. And in that case, yes, I would say it should be cycled. But
Okay.
there's no reason after that to not have the benefits of progesterone every day. And there's no harm
Okay.
that I'm aware of.
Great point. Okay. So then this is a great segue into the second question, which we got a lot. What is the difference between wild yam cream, which is marketed by many influencers on this platform and the others as a progesterone replacement, that versus micronized progesterone? And why are they both referred to as bioidentical hormone replacement?
Boy, I don't know. If some place is referring to wild yam cream as BHRT, it's mislabeled.
Okay.
What wild yam cream contains is a substance called diasgenin, and that is a building block, an essential basic starting point for the synthesizing of all the bioidentical hormones. And it starts with progesterone. They make progesterone first out of it. And that's a process that can only be done in a lab. It has no hormonal activity without converting it to that progesterone, and the body can't do it. It's a process that is done in the lab. So wild yam cream, there's no hormonal activity there at all.
Got it.
Diasgenin has to be converted to these other things, and that's what's used. We start with wild yam cream. It's the primary source for making these hormones, synthetic, manufactured, and bioidentical. So it's just important to know that that's all they are is a starting point, and they don't have any activity. So I would avoid those.
Okay.
Now
No, that's.
soy is a different matter.
Ooh, that's another one we got a lot on.
Yeah, so soy does have estrogenic activities because it has isoflavones in it. And those do have estrogenic activity. And they also have diasgenin, but not near as much as what's in wild yam cream or fenugreek. Those two are the chief sources commercially. But soy has. We'll talk about that a little bit. I think you have some questions about.
We got a lot of questions about phytoestrogens, and we're going to get to that in a second. One of the other questions we got regarding hormone replacement therapy in general, in your opinion, what's the best age to start?
The best age to start is as soon as possible after you have what they call primary ovarian failure or menopause. Now, when I say menopause, I mean official menopause, not perimenopause. That's different. And if you start estradiol too early, when you say hormone replacement therapy, okay, I guess I should clarify, because progesterone is hormone therapy. I'm talking specifically about estrogen or estradiol. You don't want to add that until later, and we can talk a little bit more about that.
Yes.
But progesterone and testosterone, those can be prescribed whenever they're needed, and that can happen, wow, at very young ages. So
That's
it all
interesting.
depends on.
Yeah, no, that's interesting because I find in my practice, especially the women that are in their early 30s that have very, very demanding careers, small children, lots of hats, lots of stress. I find that progesterone is the first to go. And it's good to know that it's absolutely safe to go ahead and start replacing that as soon as you see that start to go.
Most definitely.
Yeah.
It cannot be tied to an age and shouldn't be, nor should it be
Okay.
tied necessarily to a lab. It should be tied mostly to symptoms, which then requires you to understand what you're looking at symptom-wise. That should drive this whole thing always.
Mm-hmm.
Symptoms, how are you feeling? How was your life? What's the quality of your life?
Yeah.
Testosterone, I won't even call it a male hormone. It is every bit as much female as it is male. It's just about concentrations and dose. But it's critical, and with the massive use of oral contraceptives, and I'm not disrespecting that at all, but that crashes testosterone.
Mm-hmm.
So you have all these women, younger women, who have really no testosterone or little, if any, and so you get the stereotypical situation where he can't get enough, and she's, "Are you done yet?" kind
Yeah.
of thing.
Yeah. 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 It's interesting that you bring that up because when I was in my 20s, the solution for the symptoms that I was presenting with, anxiety, horrible sleep, I was, it was recommended I go on hormonal birth control. So I went through 3 different pills before it completely destroyed my health and my sanity. So that's actually good to know. I think a lot of women don't understand the difference between hormonal birth control and hormone replacement therapy. I think a lot of younger women think it's one and the same, and I think a lot
Mm-hmm.
of physicians market it like that too.
Yeah, they do, and
Yeah.
they are not the same because, I mean, first of all, you can't bioidentical hormone replacement therapy, bringing your body up to normal physiological levels. You can't give enough of that to be a contraceptive.
Mm-hmm.
These synthetic estrogens they have such high estrogenicity. That's what it takes in order to make the body to fool the body into thinking it doesn't need to ovulate. So
Yeah.
they're very different.
Yeah. So our next question is regarding estrogen, and you may have some thoughts on this or not, but based in your experience, why is estrogen replacement sort of what doctors are leading with at the office as you're approaching perimenopause and menopause? Why aren't progesterone and testosterone sort of looked at and addressed first?
I think it's probably just kind of a historical pattern that they've gotten into. I mean, everybody understands that what's going on in a woman when she's approaching the end of her fertility is primary ovarian failure, and that's the production mainly of estradiol, although also progesterone and another hormone called inhibin are produced by the follicle, the egg. And so it's not just about estradiol, but they think, they believe that they're doing what is right and what they should be doing in treating
I think so
that
too.
estradiol,
Yeah.
because but in fact, it's not what is indicated as a first measure when someone presents with perimenopause, because their ovaries are still producing estrogen, still producing estradiol, but what happens is that it's not a cliff. It's not a sharp cliff. When you begin, what you're doing is you're running out of viable eggs, and those eggs produce and call for the hormones. So as that, it's more like the term I use is, it's like the ovary sputter. 1 month you'll have really a poor response, or a poor call for hormones because the follicle is the quality of the follicle is not
Yeah.
that. These are old
Yeah.
now. They've been with this woman her entire life since she was a
Yeah.
fetus. So they're just not functional. And so, but yet the next month she may have still one of those potent and viable eggs, and it calls for and produces a very healthy physiological level of estradiol. So if you're just giving estradiol on a steady dose, the same every week, every month, you will miss that, and you will find that your patient is not too happy with you, because what you've done is you put them into a PMS kind of picture. High estrogen, way too high, because they're making some of their own, and you gave them a full dose as well. So that's why we don't lead with estradiol, lead with progesterone. And most women in perimenopause, those symptoms that they're having, which present as hot flashes, night sweats, irritability, mood swings, those kinds of things, they will all respond to progesterone early in that transition. As you move closer to proper menopause, which can be measured definitively in the blood with a high FSH. But the other just rule of thumb is if you haven't had a period for a year, they pretty much call you in menopause. You're there. And so at that point, then you can add estradiol when you have full control of that dose.
Gotcha.
And the body isn't going to confound it by throwing in unpredictable contributions of it from its regular mechanism. So when a woman stops responding to progesterone, that's the time when you add estradiol. And you can almost do this without labs.
Yeah.
Just listen to what she's saying, what she's telling you.
Yeah, sure, because the symptoms change and they're so clear in which they're pointing to. This is really good. So I'm taking notes. That's why I keep looking down. So what is the current risk of cancer if you're choosing BHRT, or is it safer than traditional hormone replacement therapy? Okay, because a lot of women had this question regarding cancer. I think that one study we had in the 90s is, dated, but it's just where all roads keep pointing back to. What are your thoughts on that?
It's true. That is the biggest barrier to women starting hormone therapy, in my experience. And I've seen it in my practice and the practitioners that I work closely with. It's a fear because, and it's a legitimate fear, because it stems back from when we were not using bioidentical hormones to replace these hormones as they drop. We're using synthetic ones, and especially a synthetic progesterone called progestin, medroxyprogesterone. That's Provera.
Yeah.
Those they did have increased cancer rates with those, but then a study done in 2003, the Women's Health Initiative, came up with this data that really helped us to understand who the real villain here is, and it's that synthetic progesterone, the medroxyprogesterone. The truth is, it's when you take bioidentical estrogen, estradiol, and that's the one people are worried about. Oh, it's going to cause breast cancer. My mother had breast cancer. My aunt had breast cancer. I shouldn't take it. Well, there's actually overall a neutral to favorable profile for estradiol when it's given as hormone therapy after menopause. And taking that as early as possible when you start menopause is the best way to do it. But only in uterine cancer was there an indication that it was slightly higher in women that were taking estradiol, but it wasn't statistically significant. And so you have to compare this and talk about, what about all the women that die of heart disease? And
that's the number one, right? Yeah.
Oh, it is. Yeah. And the benefits, and one of the main benefits of estradiol is it helps heart health and the vascular circulation in the heart and the brain, for that matter, too. The vasculature is supported by estradiol. So you have to just weigh that against.
Yeah.
So do you want to withhold that from all of these women on the low chance, a very low chance that they might get ovarian cancer. And some of these women, if they've had a hysterectomy, then it's not an issue. Obviously, they don't have a uterus. Or did I say ovarian? I meant uterine. Excuse me. So that you have to think about that. Think about the bigger picture. We can get too wrapped up and tied up in, oh my gosh, there's an increase in cancer. Okay, how many women die of cardiac disease?
Right.
Let's not lose sight of the big picture.
Yeah. No, I think that's really, really important. Thank you for saying that. You have a lot of women that are even commenting now that have surgically went into menopause or had some sort of treatment that pushed them into menopause. And that some of their concerns, right, after having, gosh forbid, some form of cancer is to then go on hormones and develop another form of cancer, right? So there's not enough clarity, I think is the good word I'm looking for women to really be able to make this decision for themselves. So thank you.
Yep. But it's a lingering it's lingering old information that tends to govern that discussion, and it's unfortunate. So and this is because this stuff isn't taught enough and in enough depth in medical training. They have to find this
Agreed.
Stuff. So those things tend to linger because of that, those false beliefs.
Yeah.
But it is a false belief. Now, I will say this: if a woman has breast cancer, then they can test to see if it is estrogen responsive. Estrogen can feed a breast cancer, so we don't give estrogen when there's an active breast cancer going on. But within 5 years of that, that's considered a cure by the oncology community. And yet they'll tell a lot of women, no, you can never take hormones again the rest of your life. That is not evidence-based. And you're asking a woman to take a significant cut in her quality of life to just do that because somebody thinks, well, it could feed a breast cancer. There isn't a breast cancer there anymore. It's not there. So that is, I don't believe that is sound medicine.
Yeah.
But they'll say that because they want to cover themselves and cover their bases, even though it's not evidence-based. The evidence doesn't show that.
Yeah. So again, sort of piggybacking on this sort of lingering misinformation, let's touch on phytoestrogens because this came up a lot. There are a lot of influencers that actually encourage women consuming soy or flaxseed during perimenopause to boost estrogen. What are your thoughts on dietary phytoestrogens influencing our hormones?
Well, the short answer is they do. It's amazing that this hormone estradiol, the shape of it, the configuration of it, is so common in nature that a lot of substances out there, natural products, plants, even toxins and things that are, not plants, can react with that receptor site.
Like all those estrogens in our personal care products, right?
Right, exactly. But this phytoestrogen, phyto meaning plant, they definitely have an impact on estrogen levels, and they can trigger a response in that receptor similar to estrogen. It won't be the same, it'll be weaker. So what I would say to women in perimenopause, if you feel like it gives you some benefit and it gives you some relief, then okay. I think that's all right. You may find, like we do when we try and introduce estrogen on a steady dose, there will be times when it might be too much. I don't know. I don't see it as harmful, but where I don't recommend it is after you are in full menopause, because then you have no estradiol. And what those phytoestrogens can do is they can sit on the receptor and occupy it without the same potency or power to elicit a response in the coding of proteins and the way they do, everything that they do in that process. And so basically you are you are stopping yourself from getting that full benefit of estradiol, and you're substituting it with something weaker. So
Yeah.
at that point, I say stop. Don't even do that. It's just a confounding part of the process, part of the treatment, because they're not standardized. So the response that you'll get can be different with each bottle. So can you see that this wouldn't be a good way to go on permanently going
Yeah.
forward?
Yeah.
But in perimenopause, you may find some relief with it, and I don't see harm there.
Okay.
But I know that women on that are on estradiol, and the way I started to feel really strongly about this is I saw an example where one of the practitioners I work with, she said she couldn't figure out what was going on. She couldn't get this dose dialed in on this estradiol. It turns out their patients were taking a big flaxseed smoothie in the morning. And that introduced the variability that I'm talking about. And when they stopped doing that, and she had full control over how much estrogen is coming in, and it's the right kind of estrogen, it all came together.
Yeah.
So I've seen it in real life. It's not just a theoretical thing.
Okay. No, that's great information. So another common question is, what factors would almost disqualify you from hormone replacement, or what would really identify you as not being a good candidate?
Okay, very good question. One, I would say an active hormone receptive cancer. So that could be a breast cancer, it could be a uterine, or ovarian, a testicular cancer in men. Those tumors can feed on those sex hormones.
Got
No
it.
question about it. So there'd be that. The other, usually, I mean, progesterone has really, I don't know of any contraindications to it. You get pathology back from an oncologist, and they'll say, well, it's progesterone receptor sensitive. Yes, it is. Progesterone is apoptotic to cancer cells. It destroys them. That's the effect, that's the sensitivity it has. Why would you not want to do that? I don't know.
Yeah.
But so mainly we're talking about estrogen, and there is another indication there, or contraindication. Someone that shouldn't take estrogen would be someone who has an actual coagulopathy, a blood clotting disorder. Now that means this is not the same as, oh, I know I have clots in my family because my mother, she got a clot after she'd been on an airplane trip to Europe, sitting immobile for a long time, either DVT, deep vein thrombosis in the leg, because the blood's not moving. So blood tends to clot when it gets stationary. That's not what we're talking about here. There are specific, one of them is called factor V Leiden. That is a clotting disorder that has to do with, that takes place in the liver. And those folks should not take oral estradiol, but they can still take transdermal. They can still take it through the skin, because it's the oral that goes through the first pass effect into the liver that causes a change in clotting factors. And those that have that disorder then are affected by that, and it's probably wise to avoid that in those, but you don't have to stop estrogen altogether.
Yeah.
Give it through the skin, or in a patch, or a cream, or something like that.
Okay.
And then the problem isn't there. So those are the only two I can really think of at the moment.
Again, this is just such a wealth of information, because I think there is such an alarming fear and hesitation about replacing hormones. But just because there isn't enough clarity in the online space for a woman to be able to make the decision confidently for herself. One question I do want to wrap up with, because I know you have to go, but I've been watching the questions coming in, and everybody knows any questions that they're asking during the live actually don't translate when the post goes onto my feed. So if you're asking something, I'm sorry, we're getting hundreds of questions literally as we're talking, Layne and I. But one that I continue to see that's coming up repetitively is, what would your recommendation be for a woman that's spent a significant time on hormonal birth control, maybe 5 to 10 years, and she's coming off of it, realizing maybe it's no longer serving her? What would be the best plan of attack for that?
I'm sorry, you froze up there a little bit. She's been on 4 to 5 years of birth control, and then what?
And then what would be the best plan of attack to come off of that? So
Does she
in
want to
other
get
words,
pregnant?
yeah, we're going to go get our levels tested. Should we start replacing? You know, I remember, and I'll just be honest, when I came off of hormonal birth control, I kind of ripped the Band-Aid off. I didn't have a plan. I was just feeling so awful, and I didn't really have the support. At the time, I didn't have an integrative physician. I was just working with my gynecologist. So when I came off of it, I just ripped the Band-Aid off and stopped, and that was really bad. So I don't recommend that, but I didn't really have a plan in place. What are your thoughts on preparing the body for that and the best plan of attack?
So how old were you when you
I
stopped?
was 23.
Oh, okay. So you still wanted to have children. You
Sure.
still wanted to.
Yeah.
Okay. So first of all, realize that now you have to manage contraception in another way.
Correct.
No question. Um, there is no problem giving a woman a progesterone at that age to ease them into the cliff that they're sort of going to experience there by having those birth control stopped suddenly. It's usually not a really big deal. It kind of depends on what pill you're on.
Yeah.
And the amount of estrogen that's in it, and some of them have none. They're all just progesterone, and those folks can come off pretty smoothly and be fine with that. So, I think it's on a case-by-case basis. You just have to look at what are you experiencing? If it's anxiety, if it's I can't sleep, my periods are all over the place or absent still, or those things all respond to progesterone. And progesterone is the warm blanket, soft, fuzzy hormone for women. It makes you feel good. It makes you sleep well. It's very hard to overdose on progesterone. I don't even think you can.
Oh,
So it's incredibly
how
safe.
wonderful.
Yeah, I think that's probably the key to transition.
Yeah, that sounds amazing. So
And testosterone.
yeah,
You've got to make sure that you help that testosterone back up.
so that's
Um,
interesting. So it's almost like in tandem. You're replacing
mhm,
progesterone with testosterone.
mhm. But if you give testosterone, wait a minute, what did you ask?
You're doing it sort of in tandem together, replacing progesterone and testosterone.
And yes, yes, I thought you said with. Yes. So you are, and you have to, and not forever, because you don't want to give testosterone when the body can make it itself, but it will ramp it down if you're giving it. So what you're trying to do is just kind of ease into it. And testosterone may not be, it probably isn't as important as progesterone in terms of how she feels,
Uh-huh.
but it is important. And women they get used to it not being there, and they kind of think they don't need it, or they don't realize it's not there. But testosterone is so much more than about libido and sexual things.
Right.
It's like an antidepressant, truly is. When it's low, when testosterone is low, you feel depressed, men and women. So, and I hate to see antidepressants introduced when there is not a mental health
Right.
issue.
Right.
That's not what it is.
Yeah.
So you can ease them back in that way, and that's the beauty of a compounded product. You can go to very low doses to support that transition, but short term on testosterone, and probably short term on progesterone as well. You're talking about hopefully a fully intact, capable woman. I'm talking about fertility wise, and she will resume that. But boy, it can be a rough transition.
Yeah. So this has been honestly so informative. I can't thank you enough. I know I'm going to get this question a lot in the DM. So when everyone's done watching this in the feed, they're going to say, well, what do I do? My current doctor doesn't listen to me. When you get either somebody reaches out to you, what's your go-to system of referring women, men for some really quality hormone replacement advice? Is there a link? Where would you drive people to?
First of all, if you run into that response from your practitioner, it's not likely that they're going to change that attitude. Um, unfortunately, a lot of practitioners out there are just kind of, they're just kind of set in what it is they do. And look, if they're a primary care practitioner, they're busy. I get it. They've got a lot on their plate. And for them to go and now sort of specialize in this, and that's kind of what it takes, is probably not going to happen. So just don't look to them for that anymore. I think the best resource that I have is worldlinkmedical.com. There's a provider directory there that folks can look in it, and there's a map there of the U.S. worldwide, actually, because there are practitioners all around the world. This doesn't need to be limited to the States. But look for one that's nearby you. Call and talk to them. Make sure that they're still doing it. Or do you do hormone therapy, and how long have you done it? These are folks that have been trained properly.
Yeah.
There are different ways, different schools of thought out there on hormone stuff, and some of it just is not evidence-based.
Yeah.
And when I say evidence-based, I mean that it's supported by research, by solid research. But more than that, because I don't like people to get lost in studies and not to, this social media generation right now, I'm finding is far less impressed with studies than they are with results. So they just want to know it's not going to cause harm.
That's it.
And done right, bioidentical hormone therapy is not going to cause harm. The only real harm that we can do, and I've told my employees this for years, is if we give someone estrogen and they're not on a progesterone and they have a uterus. We can cause that to be stimulating to uterine tissue overgrowth, and that's a precancerous kind of a state. So, but when progesterone is given, they work together. Progesterone counters that, and they do what they're supposed to do and have been doing since the dawn of mankind. They're protective. They work in a cycle, and that's the way it should be. Other than that, they're incredibly safe.
Yeah. Incredibly
safe. And no woman should sacrifice her quality of life because of old, outdated fears.
I think that's a perfect way to end this conversation. Thank you, Layne, so much for jumping on with me today. If we have a bunch more questions, hopefully you and I can connect again in the future, because I know I just learned a ton, and so did my audience. So thank you so much.
Well, let's do it again if we need to, if there are that many questions. Mention one other thing before I leave. Something that you said, I'm semi-retired. I am retired from the pharmacy business, but my social media focus has been on hormone disruptors, and people will have heard of that. You probably heard it from RFK Jr. It's had a lot of attention in the campaign, but this is a big factor, and I believe it's causing this plummet in fertility that we've seen over the last 50 years.
Yes.
We're about 50% of testosterone levels that we were 50 years ago, and fertility rates. It's crazy to think about that. We have not, in this country, in the U.S., we have not been at a replacement rate of our own population since 2017. We're shrinking, and that's never good. There's got to be an up and coming generation to make the system work, to contribute into the system, so that those of us on the other end, we're not left high and dry. But more importantly than that, people that want to have children are struggling, and I'm seeing them younger and younger. And much of this has to do with environmental. As I mentioned before, there's so many things that resemble that estradiol structure and can fool the receptor. So that's where, honestly, my social media has taken off. Seeing these young people just really embrace this idea that, wow, okay, we can't just continue like we are, think that everybody's going to look out for us, and safety is just an inherent thing. Now you've got to really take a look at what's getting into your body these days, and it's coming from all sides. So that's the kind of reels that I do a lot of in fertility. So anyway, thank you.
I love your content. I find so much value in your content. So if you're not following Layne, please go to @hormone_specialist. You will not be disappointed. Thank you so much, Layne. Today was great.
Well, thank you, Francesca, and thank you for the work you're doing. It's critical.
We'll talk soon.